We have David Camitta from CommonSpirit, formerly known as Dignity Health. We have Jude Soundar from the Social Security Administration. We have Ganesh Persad from Memorial in South Florida. We have Arun Gopalan from DaVita. And then we have Jeff Anderson, who's joining us here today from the Veterans Health Administration. And for better or worse, I think half of our crowd or more are physicians. So we'll take it away and see how they can enlighten us.
Thank you. Again, I'm Kevil Larsen. I'm with CMS, Centers for Medicare and Medicaid Services. I'm now also working with the Secretary of Health and Human Services, the CTO's office, supporting the Indian Health Service as the Indian Health Service looks to do what DOD and VA have done in modernizing their EHR. So brief plug, we just released a roadmap with the first 2 years of analysis, and we would love eyes on that. You can find it at the Indian Health Service website or on the CTO's website. I'm happy to be part of the coordinating committee for the eHealth Exchange. CMS is a participant in the eHealth Exchange, but we only do a little bit of inbound work around end-stage renal disease quality reporting. And I'm hoping that HHS, as a founding member of eHealth Exchange, can expand our role and place in eHealth Exchange. So pardon me while I look at my phone. That's where I have all the questions for the panel. And I would just like to start and ask each of you to kind of summarize who you are and what you see as the benefits to eHealth Exchange. So I think, David, you're first.
Oh.
If that's all right.
I don't get to cheat with my slides.
Well, if you want.
No, it's okay. So I'm David Camitta. I'm an internist by background, and so I'm currently a physician leader in medical informatics at CommonSpirit Health, which is the alignment of Dignity Health and Catholic Health Initiatives as of January 31st, 2019. Among my responsibilities and probably one of my biggest passions is really health information exchange and interoperability. At this point, we are the largest not-for-profit health system in the country, with 150,000 employees, around 40,000 physicians in 21 states, covering over 20 million lives. And that's thought to be expanding. We have basically every EHR under the sun and are exchanging information in probably any way that you can imagine. And so it's a great opportunity and a really exciting time. The eHealth Exchange is actually near and dear to my heart because when I joined Dignity and assumed a role as our leader, our clinician leader for interoperability and VHIE, that was really the federal network and federated network that we were on. And I had been in so many both informatics career settings and clinical practice settings where I did not have the opportunity to engage in such an amazing amount of meaningful exchange with our data partners in our communities. And I'm looking at the clock here, so sorry, I'm multitasking. But I was fortunate to be in a community in particular where we were initially connected. We had a lot of robust connections, and we're really able to see the value both from operational standpoint and then anecdotally from our clinicians and to in my belief of really improving care of our patients.
Great. Jude? Hi, I'm Jude Soundar. I am from the Social Security Administration. I am the Executive Director of Health IT. So as I say, you mainly know us as a retirement. We do retirement, but we also minister to major federal disability programs. And those programs help those who are disabled and get some benefits and health care if they're adjudicated to be disabled. To do those determinations, we need health data. So we make about 15 million requests per year. Only about 1.4 million or so is electronic. The rest is paper and fax. So eHealth Exchange has been a critical partner in getting electronic data. We've been working with eHealth Exchange since about 2009. We have 176 partners through eHealth Exchange. That's a huge amount. That's a big number, and we get about 1.4 million electronic documents through eHealth Exchange. So, critical partner for us to get more electronic data. We have very stringent requirements around what data who we connect with and how we get that data. We have a requirement for those clinical notes. We need sensitive information. So we need that plethora of data to make an accurate disability determination. All of our requirements to connect with us are both on our Health IT government website and our GitHub site at SSA.gov Health IT. So eHealth Exchange has been a super important partner for us to increase the amount of electronic data in our workflows. So we look forward to continuing that partnership. We look forward to connecting with more partners through the eHealth Exchange. We are now currently piloting a connection with the Care Quality and looking to work through the hub. I think that's going to be around springtime for us, but very excited for those opportunities to expand connections with healthcare providers and getting more electronic information in our workflows for disability determinations.
Cool. Ganesh?
How you doing, everyone? Can you guys hear me? Ganesh Persad. I'm the manager of Interoperability at Memorial Healthcare System. I've been in this role for about 2.5 years. Came in as an analyst and now overseeing all things interoperability at Memorial. And one of the first things that I had to do was get us live with some of the national frameworks, right? So Care Quality and eHealth Exchange. The eHealth Exchange has been key to our organizations. So working with the SSA for disability claims, we're live with DaVita, but not only those national and the VA. But in addition to that, working with our state HIE and connecting through the state gateway to some other organizations that we couldn't have done independently. And I'm looking forward to the hub, to becoming an implementer so that we can start querying to a vast majority of other organizations throughout the eHealth Exchange.
Cool. Arun?
Yeah, hi. I'm Arun Gopalan. My primary role is IT business relationship management for DaVita. So as part of that role, one of my accountabilities is technology strategy for interoperability, which is where the eHealth Exchange comes into the mix. I think several people are aware of DaVita, but for a couple of people that may not be aware, DaVita is the largest provider of kidney care services in the US. So we have over 2,600 dialysis clinics, as well as other businesses, and over 200,000 patients. So it's a pretty big population, and I think in conversations here, it's evident that when you solve for state stuff, we always get left out because we are a national player like the VA. And so which is where eHealth Exchange is such a critical piece of our interoperability strategy. eHealth Exchange is national and it provides us the coverage we need, and now it's super exciting with the hub that the coverage perhaps even increases more. So as a patient population, our patients deal with multiple comorbidities, and so they are in different care settings. So interoperability is a key piece of our transition from volume to value as an organization. And eHealth Exchange is a key piece.
Great. Jeff?
Jeff Anderson. I'm one of the other physicians here, emergency physician, but for the last 10 years been involved in 2 large integrated systems, led the implementation of these 2 systems. Importantly, utilizing for interoperability a regional HIE, new to the VA. For the last 2 months now, I am the director of the Veterans Health Information Exchange. My predecessor is in the audience, shaking her head yes, so I guess it's okay. So, at any rate, and relative to eHealth Exchange, you know, the VA and VHIE, the Veterans Health Information Exchange, was one of the founding partners to the antecedent entities that is now eHealth Exchange. And we have 3.6 million veterans who, through the eHealth Exchange, have been identified with one of our community partner entities. And we have, just this year, in 2019, we've already exchanged 3.3 million records, mostly CCDs, through eHealth Exchange, through our working with them, and received back 1.3 million relative to the queries out from our veteran providers. And we are hooking to the hub and look forward to our 200 plus community providers, I shouldn't say providers, community partners, multiple providers under every partner. Hopefully, most, if not all of those, equally hook to the hub, so we reduce the number of connections that we have, point-to-point connections. Trying to maintain 200 is quite a project. So we look forward to that, and I'll turn it back to you.
Yeah, so maybe to continue playing off that, so as the hub becomes more and more of a reality, can you guys talk about how the hub is fitting into your strategy or into your current operations? What opportunities do you have? How are you looking at the hub?
So, I mean, we want to expand the amount of electronic data that we get. So the hub is going to open up all of these providers that weren't available to us. So that's a huge deal for us. Also, the hub, instead of maintaining many connections, right? We have 176 through eHealth Exchange. We would like to reduce the amount of connections. It's less maintenance for us, and we can redeploy those resources for other opportunities. So hub is a big deal for us.
Others?
I mean, I would echo the same thing. So I think we have spent a couple of years and we have 90 connections so far. This is the rate at which you can go point to point, and it clearly is not scalable for national providers. So hub is such a key piece of our strategy, and it frees up our resources to focus on more value-added stuff than going after connections and waiting for technical upgrades and so on and so forth.
From our perspective, I echo all the comments. It's really being able to dedicate those people who had been, managing the myriad of point-to-point connections to the single, and then the performance is much more streamlined, as well as getting more robust utilization data and analytics. And then, from our standpoint, it's about scalability. So, scalability is really there.
Yeah, I mean, I think a common theme for many of us is we're national providers, and trying to understand and deal with 50 or 65 plus different state HIE systems is possible, but it's actually costly and difficult. And so having an organization like eHealth Exchange that already helps us get a long ways down that path. I know it also at CMS, it's easier to describe the benefit of exchange when there's a national exchange. As I talk to different potential business owners within CMS, and they say, well, I can help you connect to this one great state HIE, and they're like, yeah, but what does that do for the other 49 states we have to serve? So CMS is often trying to think of scalable national solutions, and that really becomes much more possible with the hub. In a related way, this now, our new opportunity to connect into care equality. Can you just talk about how you're going to leverage that? What do you see as the benefit or the strategy you have around the care quality connection?
So I can speak to that. So we're connected to care quality independently. So for us, there really isn't a need to go through the eHealth Exchange. But I think from a state level, right, if our state HIE can connect through the care quality framework, that's going to be a benefit to our community providers, a lot of the smaller independent practices, ACOs and so forth, that want to get access to that data. So I think that it's a gateway to somewhat almost endless possibilities in our state.
Go ahead. I'm going to say the same for the VA. The care equality will allow us, we have 216 right now, rather large community partners, but how do we pick up the smaller ones? And the care equality framework moving forward will allow us to do that. And again, through a single hub, one connection to us. If we're already at 200 plus point to point and going to the future and more interoperability, that becomes just economically unfeasible. So care equality just gets us one more step in that direction.
Yeah, and I echo the comments about my federal colleague here. It just expands the opportunities to connect with many providers that we wouldn't have any access to.
Yeah, in our space, we're using every EHR under the sun, and then on the Cerner side, we're really fortunate to have leveraged the Commonwealth implementation through care equality. It's just opened up the amount of connections, and then really, as was stated before, touching the ambulatory space, which is where the majority of care is delivered, and then enabling things like really robust care coordination and the initiatives for really truly caring for populations.
One of the things that we had to deal with when we went live with care quality was the education to the community providers. A lot of them have ECWs, they have some of those key EMRs, but they didn't know they had the functionality to turn it on. They didn't know how to do it.
Interesting.
So it was kind of boots on the ground, getting out, working with our health network providers, getting an inventory of all the providers and what EMRs they use, and basically educating, training them on how to onboard to care quality. When I took over and we went live with care quality, there was probably 25% adoption rate. Now we're at about 85 to 90% adoption rate because we're getting the word out there.
Yeah, I think for us, one of our key stakeholders are the nephrologists, being in the dialysis business, and we constantly get asked, when are you going to give your data in Epic? So we believe care quality is the answer to that. So we're very happy to go and share that back with you.
Very cool. So you've all talked about how there is some efficiencies with the hub. So what are you going to do with the freed up resources from those efficiencies? What are your new priorities that when you no longer have to make individual connections and you don't have to negotiate all these agreements, what are you going to use that capacity for?
Yeah, couple of things. I think one has been the recurring theme here. How do you go upstream on data curation and quality? So now those resources can focus on thinking about some of those problems as opposed to connecting. And the other big piece is also internally focusing on utilization. You have all these connections. Now, how are our clinics going to use it? How are we going to better support them? I think those are some of the things on our mind right now.
Yeah, and one of our strategies on our pop health roadmap at Memorial is care coordination and our case management team, making sure that they're using the data that's available to them in an actionable fashion to truly have continuity care for our patients. And I think another area is that we're going to focus on, now that the resources are freed up, is remote patient monitoring and so forth, is some of our additional strategies that we're going to free up resources to kind of focus on other things.
I think opportunities for us, it would be kind of free up resources to look at analytic opportunities. We have all the structured data, keeping that data structured. I think that's really important. I think we could learn a lot of things from that data. It's very valuable data. So that's a huge deal for us. We also need to check the downstream usage of our health data, make sure it's utilized properly in our processing of doing disability determinations. That's a key goal. Maybe there's opportunities to modernize processes downstream. So that's a huge opportunity for us too.
Yeah, and I think to build off of that, one of the areas that we struggle with too is that with our clinicians, there's an abundance of data in our system, but it's the use of it. What are they doing with it? So I think, shifting some of the resources to actually, again, getting out there, training, educating them, showing them that this is things that you need to do, and it's available for you.
Yeah, I would add to that as well as to redeploy the meaningful usability of it from a clinical standpoint, and engaging in the partnerships in our communities with exchange partners that we already have to see how we can better deliver this at the point of care, and then really just the more we can get into the data and analytics, then we can really look at outcomes.
Jeff?
And I think we've touched on it here, but just to summarize again, especially being a physician, at the other end when you're taking that interface. As we all know, interoperability has been the goal that we've all set out to achieve 10 years ago, 15 years ago, even longer. We're getting very close to it, and now that we're freed up technically, like through the eHealth exchange, not maintaining 200 plus point-to-points, we can start focusing on, one, deduplicating data, two, the quality of the data that comes through it. And we all know, and I'm sure you all know, sometimes the data that comes through on those CCDs is interesting. And then lastly is that interface with the user. And both ways, for our community partners, the data we're getting them, and also for our providers in the VA. If it's not easily usable, and this we can focus. So now we got the interoperability, we got the data there, the complete longitudinal record, hopefully, and if we can deduplicate it, which will be interesting, but if we got it in front of them and we focus on that, we'll get the use of the data, which was alluded to earlier this morning. So it's very important.
I was seeing a slide about the cognitive ability of anybody to use data to actually make decisions, and we're soon past that from what we can now generate around an individual patient. So I think that it's going to be a really interesting question for us, how we sort, filter, and focus data for the right user at the right time. Right. I think it's going to be a big business opportunity, a big organizational opportunity, because as we all know, there are also risks there, right? If we focus it wrong and filter it wrong, we actually filter out the key important things that actually
matter.
Yeah. Right. Well, and as clinicians, it's the one piece of data that could have finally made the diagnosis that got filtered out, and that's the last thing you want to have happen. So there's a lot of opportunities, but also challenges in figuring out how to help humans deal with this amount of data in an effective way.
Yeah, I really approach it from sort of the best practice of CDS with the 5 rights.
Yeah, absolutely.
And so if it's not the right information delivered to the right person at the right time, to the right channels, in the right trigger, integrated, and also that whole signal to noise ratio,
yes,
and really decreasing the noise, because the way that we know that alert burden and alert fatigue really creates patient safety risk. This also having all this extra data noise, just like you said, you miss critical points of data, or you just tune it out because it's not consumable when you need it.
Yeah, and then there are all sorts of data reconciliation issues. We did a big project in the state of Minnesota when I was there about transfer of information between hospitals and long-term care. And what we found was we were over-signaling long-term care, and they used to get one paper record and they knew what the source of truth was. And we would send them 8, 10 versions of the same thing, and they suddenly were having a whole bunch of new patient errors because they couldn't sort through the 8 versions of the same document we sent them and know which one was definitive. So I think all of us are facing these same kind of questions about how do we really help assure safety and accuracy of information as we get lots and lots of pooled data coming at different times and places. A little bit of a pivot here. How would you advise eHealth Exchange about what directions eHealth Exchange should focus on? What should be priorities or strategic thoughts for eHealth Exchange?
Some of this is my personal thoughts, but I think as a federal agency, I think we're really, cybersecurity is super important for us, so that cyber issues are a big deal. The other issue I think is, as data is coming in, I think there's a great opportunity for front-end analytics, like we have all of us have this deduplication problem, right? I think there's a big opportunity to position some kind of analytic system in the front.
Yeah.
I could do some kind of scoring algorithm. It's like, hey, this could be a duplicate. It could be valuable information for all of us, I think. So I think there's some of the opportunities there.
Yeah, I think to build off of that, with the shift to value-based care, and a lot of healthcare organizations are going risk. They're having risk contracts and so forth, and you're responsible to close those care gaps for those patients. Using the data that's available to us, not just eHealth, but just any HIE, state, care quality or whatever, to kind of have a mechanism in place to kind of suggest to clinicians like if they had a hemoglobin A1C and they had a care gap closure and it needed to be closed, that it's available in an external repository, that it'll automatically do it, or that that community provider can close that care gap for that patient because they have that information. I think that's 10, maybe not 10 years, 5-10 years from now, but I think we have an opportunity there if we're now having the technology work for us to kind of align ourselves.
I mean, I had a couple of thoughts. I think one, I was like really, it was nice to see as part of your roadmap, Jay, that you are looking more into the push side of things. So that's something that is critical to us, to free up our clinicians' time, just letting them know where they need to look for information and when. I think that's very critical. So whether that is some type of an ADT message or whatever, I think some type of push location services is great. Some type of push is critical for us. But kind of in the long term, I would definitely like or would love to see eHealth Exchange tackle the whole social determinants of health. I mean, that's an opportunity. There are so many different agencies. There are no standard data mechanisms to exchange and so on. So I think it feels like somebody needs to take that and figure it out. And I think as we transition from volume to value, that is a key piece of something that we need to tackle. I mean, it's on top of all business leaders' head, and we need somebody to put that.
I'll just put a plug in. There's a project called the Gravity Project, which ONC is helping to coordinate around creating some set of standards for social determinant of health data. So if anyone's interested, it's an open group that you can collaborate in. I've been part of some of it. There are some tricky, thorny questions in there. We were on a phone call dealing with home-delivered meals, and there were 2 hours of discussions about what level of granularity of types of home-delivered meals should be in the standards, in the first set of standards that come out. So all the same kind of standards discussions that you've had in the past, bring in a whole new set of sectors, and we're having those same discussions again. But it's the right, important foundational work. So anyway, the Gravity Project, if anyone's interested.
I mean, I would also put a plug for the same thing, because from what I read, you're tackling the most important issues first: food, housing, transportation, and
Yes.
Yeah.
And that's, a core mission for us in our organization is the whole social determinants of health, and then adding that in as meaningful data that actually we can drive towards predictives to keep people healthy and identify those gaps. I'll just also say every single stretch goal that I saw this morning, if you're listening, that those are all great. So, the stuff we talk about push, we're always getting asked for really, really accurate sort of like event notifications and push notifications that help with that decision support, image exchange, adopting new standards such as FHIR and sort of that, really carving out the special stuff so it really becomes more and more meaningful.
Others, what strategic priorities?
Kind of just a practicality for us is the PDMP and the immunizations, the state registries. Again, it's like connecting the regional and state HIEs. If we can do that through the exchange, through the hub, through care quality, lying on top of it, the framework, that will just move us, again, steps forward for a complete longitudinal record so our providers can trust that we can give them all the data.
And are you looking for bidirectional there, like within
Yeah. Which gets in sometimes into an well, it's because they don't, like a state registry doesn't provide care. So how do you?
So while we
Immunization registry.
while we see all this, I think also concentrate on the core mission to expanding to get as many healthcare providers through eHealth Exchange, and so that we can get more electronic information, so that we can provide benefits to those claimants as fast as possible. So sticking to the core mission, make sure that we expand to as many healthcare providers as possible.
Yeah, one more. So one area I think where all across all the HIEs we're lacking is like post-acute. Working with some of those post-acute vendors, whether it be the vendors directly or some of the intermediary pseudo HIEs like Point Click Care, having a relationship with them so that we can have access to that data. I think that's another opportunity for us, and that'll definitely help drive care coordination amongst healthcare facilities across the nation.
So if you had a magic wand and could change one thing in interoperability, what would it be? What would be your one, like, this is the thing I really, really want?
Consent model.
Yeah. Say more about it.
So recent example. We have a local healthcare organization. They went live with Commonwealth or Cerner Shop. We're connected to them through Care Quality. And I looked at the stats, and we're sending thousands of records to them. We've received 60. Why? Because they're an opt-in. And we saw it firsthand when, before I took the role, we were an opt-in organization, and I knew, in order to truly promote interoperability at our organization, we had to change our consent model. Yeah. So the stance was, we got to change our consent model first to opt out, and then work on connecting to the national players. And in a year that we made the change, we went from exchanging 500,000 records historically to quadrupling it in a year after we made our change. So if we could do that in a year, can you imagine what we could do at a national level if there was more incentive to have everyone change to an opt-out consent model?
Maybe super exciting for everybody, exciting for me. A topic nobody wants to talk about, but we always do, is patient matching MPI.
Mm-hmm. Yeah. That's also a huge deal. Locating the correct person we're supposed to get data from is a huge deal for us. There's no universal system to find out what the healthcare provider was that they went to. Yeah. So that's a huge deal for the country generally.
Yeah, I would kind of echo the same theme, but take it broader. As a national provider, you need to deal with different states and their whims and fancies in terms of regulations and so on. I think it would be super cool if that can be simplified, so you know what you're tackling instead of having to deal with each separately.
Yeah. Jeff?
I would say the ontologies that go into making the records that we share, because that will help us for deduplication. We all know that they don't necessarily all overlap. And I know there's efforts out there, but I think we have to tackle that as a group for interoperability to move forward, because otherwise, when we get up with the numbers, like you saw when you changed, and the VA is equally changing from an opt-in, it was per the Mission Act from 2018, to a model where we will share unless you opt out. With the number of records that will start coming in, and we have to deduplicate them, and we can't rely on the individual providers to be the filter.
Right. Yeah.
So we need to have standardization so that we can do whoever brought up the algorithms.
Yeah. Arun has another one.
Can I play moderator for one question?
Yeah, of course.
I was just curious as to how you all set expectations with your clinical teams on interoperability. There is palpable excitement generally around interoperability, and when you throw something like a hub, hey, we are going to get all this cool connectivity. So I was just curious, how do you set expectations with your
I don't have any clinical team, so no issue. We provide benefits, so it's a non-issue. But I see what you're saying around, I think you were talking about GUIs and issues with how to view the data.
And not just that, just how do you help your clinical teams think about interoperability?
So I can speak about it. When I was implementing in a health system in a state that was kind of early in interoperability in Minnesota, what I eventually learned was that my clinicians would stop, when my clinicians stopped yelling at me, then that meant they were finally happy. And, but also that clinicians especially are really sophisticated users of high amounts of really heterogeneous data. And they're really tricky consumers to actually make better than what they're trained to do in their own brain. And so they get quickly used to whatever amount of data you're pouring at them and now want more. And all they can do is think about the delta between what their ideal is and what they currently have. So I found it to be almost an impossible lake to fill, because as much as you give them, there's always 2 or 3 other little things they need to be able to make a really good decision. As a clinician myself, I agree with that, right? So I was constantly working to get as much as possible to those clinicians and in the best possible way, but also pretty comfortable that I was never gonna really fulfill their platonic ideal of everything they need.
Yeah, I would echo that. I was there when for our Dignity Health, we went live with the physicians first and started delivering connections to them at the point of care. And it quickly went from, oh, this is so cool to, you know, the list of things.
Yes.
And the list of how it's wrong and what's missing and how it wanted. So they quickly sort of like shift. And I think it's expectation setting. And, you know, that's the thing, to frame it, we're all used to getting and looking at that information in context of our clinical workflows. And it quickly sort of, you know, having, you know, it's a challenging translation and explanation to sort of like delineate. So, you know, it's one thing, they're not even used to EMR's 1.0, but they're sort of used to how that information is delivered. Now how it's coming in through standards-based exchange and, you know, sort of the usability. And so it's a constant, it's an iterative education process, but, you know, the response is overwhelmingly positive.
Yeah.
I think it comes down to that user interface. And in the VA, they have what's called, and in the DoD, the Joint Legacy Viewer. And the key is when the individual clinician is looking at the data, to your point, they can assume heterogeneous data and analyze it and come up with a clinical decision, but they don't necessarily, it's that right data at the right time.
Yeah.
So I might want to see this, and for that particular clinician, whenever they see this, they'll want to click on a little link that'll bring in the extra.
Exactly.
Don't show it to me up front because you're going to overwhelm me. But I want it all there. I want that complete longitudinal record, including those immunizations that are recorded in the state registry when I want them.
Yep.
You know, so.
So we have about 10 minutes left. We're going to open up to questions. So fire away. We're all happy to answer. Maybe while people are coming up, I'll share if I had a magic wand. I'm a radical patient centrist. My request would be that we are really routinely and reliably getting usable data to consumers when and where they want it in their workflow. I recently had to have a skin biopsy, and I got a notification of the result on my smartwatch. It was the coolest thing ever. I'm integrated through the new Apple Health app to my PHR, and that alert came all the way to my smartwatch. And like, this is what I've been working for the last 15 years. I'm glad it's finally happening, but we need a lot more of that.
Right.
Yeah, I'm a personal proponent of the consumerization of data in all verticals, but definitely with health records. I wish we could also be like finance and banking so that we can know everything about all of our data in a Mint-like app. So.
Yep, agreed. Question?
So I asked this question because we ask it with our stakeholders all the time. What's the biggest issue you find with the interoperability you have in place right now with the data that's actually flowing, you know, with use of it, the actionability of it, quality of it, just kind of feedback would be helpful.
I think usability and quality go hand in hand, and so that's, you know, it's a short answer, but that's really from a clinician standpoint. It's really it being integrated, the right information when they need it at the right time, in the context that they need it. So from a clinician standpoint, I know there's a bunch of technical aspects to it, but that's
One of the complaints that we get all the time is, well, you know, Epic to Epic, I can get this robust CCD. Right? It has a lot of information, even like our oncologists, you know, Epic came out with like an oncology specific CCD. But then when they go for the same patient and they get a non-Epic site, and it's like, well, I only got this much. So that you know, getting them to understand that, you know, not everyone plays the same rules, but that's definitely one of the frustrations that I hear constantly.
Yeah, I would say unpredictability, right? I think it's sometimes you get into the exchange and you're not seeing the patient you're supposed to see, and then you find out it's a patient matching or whatever be the case. Just the whole unpredictability of dealing with, hey, would I get an information back or not, is challenging.
From a CMS standpoint, I've been involved in a lot of the value-based care quality reporting requirements. And both of the centers and CMS are looking for data we can make a value-based incentive payment on. So the data quality and accuracy is exquisitely important there. And providers are commonly concerned that we are not getting high enough quality of data, and we're concerned in the same way. But we're working to be able to make incentive payments and payment adjustments on the quality of the data that comes in through this interoperable world.
So for SSA, we have strict requirements on who will connect with we have strict requirements on what data we require, and we'll check that.
Yeah.
If we don't get it, we're not going to connect with you. So.
Other questions?
Hi, this is Cindy from VHIE. I have a question for some of the participants on stage whose organization is already possibly working with the social determinants of health, and how you guys are incorporating that into clinical usage to improve patient care.
So we're in the very early stages of implementing Aunt Bertha. It's a third-party application, and it integrates with Epic so that if a patient has a social determinant need, let's say it's food or housing, Epic has incorporated a wheel that shows a deficiency, and it suggests food pantries or housing facilities in line with the clinician's workflow, so they can refer out to those facilities, and then once the patient goes there, it'll kind of close the loop and come back into Epic.
Yeah, I mean, we have only barely scratched the surface on this. I think we did a couple of transportation pilots, but nowhere near solving this.
Yeah, there's disparity in across our platforms. Probably the most use that we're leveraging is using Epic, which has some predictive tools involved. That is baked into their pop health stack as well. So we're finding that of value. And again, there's variability in how in the levels of deployment. But the next part is that there's capability from talking about the patient-centered aspect to actually deliver that kind of information to the patient at the time when they're actually engaging with their care team, so that they can proactively start to access those resources in the community.
When I was at a health system, it was a county health system, and we had an ACO that focused a lot on social determinants. And so we routinely collected the social determinants on entry into the ACO, and then we case managed, and we prioritized patient case managers based on your primary need. So if your primary need was housing, you got a housing case manager. If your primary need was job, you got a job case manager. If your primary need was behavioral health, you got a behavioral health case manager. And if it was medical, you got a medical case manager. And then we coordinated all that through our electronic health record and tracked both your health outcomes as well as your kind of social supports through all these various county connections. It was really fun and an incredibly powerful way to get the right resources to the right people without a lot of waste. And the health providers loved it, because then if you primarily need mental health case management, that's what you got. And we had enough information to know that it was happening, but we didn't have to try to take on your mental health case management as a primary care clinic.
So I was just going to follow up externally. So we built in social determinant systems into Epic before Epic had their wheel module. And currently we've collected about 350,000 patient direct screenings into the EHR. From there, we create a determination of the social need of that patient, be it housing, transport, nutrition. And then we're integrating that further, taking trigger mechanisms to allow the provider to look at the information, place the order out to the social agency, and have the social data then come back in from those social agencies. So did the patient turn up for nutrition services at a food bank? If they did, was it closed out? And then have caseworkers that actually then run that process through for public health and other ambulatory providers. So happy to talk to you. We have a couple of white papers out there on it as well.
Another question.
Michael Marchant, UC Davis. So one of the things that interesting about the opening up of data to the APIs is patient consent and understanding of what they're consenting to. We've all seen the news with Google and how that may end up playing out, whether that's under TPO or not. But anyway, I'm interested in understanding from a consent management standpoint, and as these apps get plugged in, is there a consent model that the eHealth Exchange is looking at, or organizations are looking at, as all these new web-friendly apps driven by consumers are accessing data? And we're connected with Apple HealthKit and went through all the meetings with Apple. They're not storing the data, it's really just on the phone. So how these intermediaries work and what your thought is on that.
So I can talk a little bit about CMS. We have the Blue Button Initiative and the My Healthy Data Initiative. And one of the things that is important to understand is that patients are not covered under HIPAA. As soon as you get your own health information, it's yours to do with. It is, like cash or whatever else, it is your own. And so it's not covered under the same security and privacy rules as soon as you are in possession of your own data. So there is a lot of, you have a lot of power in managing your own data, but there's then some risk when you have it in your own personal possession. I don't know if others have thoughts about what you're doing there.
I mean, so we have an opt-in model right now, so that's what we follow. So it's kind of slightly on the conservative side, but that's what we are comfortable with. Yeah.
So we're a privacy-covered entity, so we have a separate form that authorizes us to get data. So that's signed by the claimant. So we have a totally different model. So we're also outside of it.
And our opt-in consent, opt-out consent model encompasses all that in our notice of privacy. So if they know what we're releasing to.
Yeah.
And if we integrate with others, we update our notice of privacy accordingly.
Yeah, and to be clear about CMS, if someone's asking on behalf of you, then absolutely we have to get consent from that Medicare beneficiary. But if you're getting your own data, it's your own data.
This will need to be the last question as well, too. So we need to move on. So.
Go ahead.
Hi, Brittany from Centera. One of the issues that we've been having is it kind of goes along with what everyone was talking about. It's the opt-out option now, and we actually had to remove that from our patient-facing application. We have our own that we've homegrown, and then we also have MyChart. But within the MyChart one, we had to remove all of that because what we were having people doing is they didn't understand. They thought this was just exchanging data, and they didn't really understand what we were doing, as in, you know, this is basically could save your life if they don't know your information and they pull that information and you're allergic to something. But what have you guys done to kind of, is there like a certain type of consent information or process that you guys follow that allows us to communicate what it is we're doing to the general population that's making that decision? Because we're just getting a bunch of people saying, I want to opt out. I don't want people having my information. I don't want them having my data. I just didn't know if there was anything that you guys implemented.
Yes, so when we had our opt-in consent model, the adoption was very low. We only had about 30,000 patients historically that were opted in. And the onus was on our registration staff to kind of communicate that out to the patient that they can opt in to share their information. When we made the change, we put that onus back on them. And again, education training. So when they're registering a patient, that they explain to them that we are an opt-out organization, your information will be shared across, and you have the right to opt out. And I think to date, we've only had about 30 patients opted out. So there's an appetite there to have their information be accessible, and they see the benefit in doing it.
Well, thank you all. Our time is up, and we'll have the next panel come forward.